Hello, everyone, and welcome. Today, we are going to get stuck into a topic that we all deal with day in and day out, anesthesizing patients with respiratory disease. We'll be zeroing in on those common headaches, like the patient with a cold, and then taking a deep dive into the whole range of obstructive lung diseases.
But just before we jump in, I wanted to say a quick word to all of my colleagues listening. Thank you for your hard work today in anesthetizing a challenging patient for a complex surgery. Merci pour votre excellent travail aujourd'hui. Gracias por su arduo trabajo hoy. It really is a tough gig, and your skill and dedication are what make all the difference. Right then, let's get started.
So here's our plan for this explainer. We're going to kick things off with that classic preoperative puzzle, the patient with an upper respiratory infection. Then we'll get right into the nuts and bolts of managing asthma and COPD. After that, we'll look at some of the rarer obstructive conditions, tackle the ever-present risk of a PE, and finish up with the ultimate respiratory challenge, lung transplantation.
Okay, let's get right into it. The acute upper respiratory infection. Honestly, this has to be one of the most common preoperative hurdles we face. It puts us right in that tricky spot, doesn't it? Do we push on with an elective case and risk a respiratory complication, or do we postpone, which messes up everyone's day, especially the patient's?
So, you know the scene. You walk into the anesthetic room, and your next patient for a routine list is there. Coughing a bit, nose running. What's going through your mind? It's rarely a simple yes or no, is it? The decision really boils down to a few key factors that we need to work through every single time.
Right, so the absolute deal breaker preoperatively is any sign of a systemic illness. If they've got a fever, a nasty productive cough, or you listen to their chest and hear raunchy, the risk of things like bronchospasm or laryngospasm goes through the roof. In that case, postponing is almost always the right call. And here's the kicker. Even after all the sniffling stops, that underlying airway hyperreactivity can stick around for ages. Some studies show for more than 6 weeks. Now, if we do decide to proceed, our intra-op goal is simple. Don't annoy the airway. Keep them well hydrated to thin out secretions, and if you can, using a laryngeal mask instead of an endotracheal tube is a great way to reduce that stimulation. And then post-op, we just have to be on high alert. Bronchospasm, laryngospasm, and DSATs are common, but if we're watching for them, we can jump in quickly with a bit of supplemental oxygen and stop a small problem from becoming a big one.
Okay, on to our next big topic, asthma. Now, looking after an asthmatic patient is so much more than just making sure a salbutamol inhaler is nearby. It's about having a solid plan that covers everything from getting them in the best possible shape before surgery to knowing exactly what to do if things go wrong in theater.
You know, figuring out a patient's specific asthma triggers is absolutely fundamental to our preoperative assessment. This table gives a really nice summary. We always ask about things like pollen or dust, but we have to be just as sharp about the drug-related triggers. Knowing if they have a sensitivity to aspirin or other NSAIDs is vital. And this is a big one, beta blockers. And I don't just mean tablets. Even topical beta blocker eye drops for glaucoma can set off a life-threatening bronchospasm in a susceptible patient. It's one of those little details that can have massive consequences.
This table is brilliant because it really tells the story of what's happening physiologically during an attack. As anesthetists, we need to look past just the FEV1. Hone in on that PaCO2 column. You see, in a mild or moderate attack, the patient is working incredibly hard to breathe. They're hyperventilating, which actually blows off CO2 and drives the PaCO2 down. But the second that PaCO2 starts to creep back up towards normal or worse, goes above normal, well, that is a hugely ominous sign. It tells you their respiratory muscles are exhausted and they are on the verge of respiratory collapse. A normalizing PaCO2 in a wheezing patient is never good news. It's a massive alarm bell telling you to act and act fast.
Right. Let's chat about pulmonary function tests, specifically the flow volume loop, because it gives us such a fantastic visual of what's going on. On the left, you've got your classic obstructive pattern. See that scooped out shape on the expiratory part of the curve? That's the hallmark. It shows that after a quick peak, their airflow just dies off because the airways are collapsing. And notice how the whole loop is shifted to the left? That's your air trapping, increased lung volumes. Now compare that to the restrictive pattern on the right. It looks like a miniature version of a normal loop. It's tall and narrow, but shifted to the right, showing that the total lung volumes are just smaller. It's also worth remembering that a fixed obstruction, like a tracheal stenosis, will flatten both the top and bottom of the loop, whereas a variable obstruction will only flatten one or the other, depending on whether it's inside or outside the chest.
Understanding the drugs is, of course, absolutely key. The whole philosophy of modern asthma care has moved away from just relying on reliever inhalers like salbutamol to controlling the fire, the underlying inflammation, with preventer medications. That's where things like inhaled steroids and leukotriene modifiers come in. We have to check that our patients are actually taking their controller meds regularly. The beta agonists are still our go-to for an acute attack, and don't forget anticholinergics like ipratropium. They can be a brilliant addition. Here's a crucial clinical tip. If a patient tells you they're using their blue salbutamol inhaler more than twice a week, that, by definition, means their asthma is not well controlled. It's a sign that their inflammation is winning, and they are at a much higher risk of an intraoperative event.
When you're clerking an asthmatic patient, having a mental checklist like this is so useful. We need to do more than just write asthma in the notes. We've got to really understand its severity. How often are they in A&E? How many times have they been admitted? But if there is one single question you must always ask, it's that one on the second line. Have you ever been intubated and put on a ventilator because of your asthma? If they say yes, that is a huge, flashing red light. It tells you immediately that this patient has severe, life-threatening disease and they need your absolute A-game and a rock-solid plan.
Okay, so this is the scenario that makes your pulse quicken. You're cruising along in a case, everything's been fine, and then suddenly the ventilator starts alarming. You put your stethoscope on the chest, you hear a wheeze, and the peak airway pressure is shooting up with every breath. The immediate gut reaction is to think bronchospasm, but we have to take a breath ourselves and think much, much broader. What else could this be?
And this table just lays it out perfectly. Before you even think about reaching for the salbutamol, you have to rule out simple mechanical problems. Start at the patient and work your way back. Is the tube kinked? Has it slipped down to the right main bronchus? Is there a massive plug of mucus blocking the end? These are common and thankfully easy to fix. Then you have to ask yourself, is the patient just too light? Are they trying to cough or breathe against the ventilator? And then you've got to consider the really scary stuff. Have they aspirated? Are they in pulmonary edema? Could this be a PE or a tension pneumothorax? It's only after you've quickly but methodically run through that list and ruled everything else out that you can confidently say, right, this is an asthma attack, and treat it as such.
All right, let's change gears now and move on to our next big topic, chronic obstructive pulmonary disease, or COPD. Now, it might share that obstructive label with asthma, but really, COPD is a completely different animal. It's all about irreversible damage to the airways and the lung tissue itself.
You know, COPD isn't just one thing, it's a whole spectrum. This table does a great job of contrasting the two classic types. On one side, you have the blue bloater, the patient with chronic bronchitis. Their main problem is all about mucus and airway inflammation. This creates a huge mismatch between ventilation and perfusion, making them really hypoxic and chronically hypercarbic. That in turn drives up their pulmonary pressures and often leads to right heart failure, or cor pulmonale. Then you have the pink puffer, the patient with emphysema. Their problem is different. It's the physical destruction of their alveoli, so they lose elastic recoil. They manage to keep their gas exchange going by breathing really fast at high lung volumes, often through pursed lips. This keeps their PaCO2 normal, but at a terrible cost of being constantly, exhaustingly breathless. Knowing which type your patient is closer to really helps you predict what their specific risks are going to be.
Now, the really tricky thing about COPD is how it completely changes the architecture of the lungs. Because the airways collapse too early on expiration, patients can never fully breathe out. Air gets trapped. This leads to a huge increase in their residual volume and their functional residual capacity. Now, you might think this hyperinflation helps by propping the airways open, but it creates a massive mechanical disadvantage. It flattens the diaphragm, our main breathing muscle, making it weak and inefficient. This forces patients to rely on their neck and shoulder muscles just to move air, which is incredibly tiring and burns a ton of oxygen. They are literally working flat out just to breathe at rest.
The GOLD classification is how we objectively grade how bad someone's COPD is based on their spirometry. While asking a patient how far they can walk tells you about their daily function, this FEV1 measurement quantifies their actual airflow limitation. When you see GOLD stage IV in a patient's notes, that should immediately tell you that this person has basically zero respiratory reserve. Our anesthetic plan has to reflect that. We're not just thinking about getting them through the surgery, we need a clear, proactive plan for getting them off the ventilator because they are at an incredibly high risk of postoperative respiratory failure.
So how do we actually reduce the risks for these patients? Well, this table is basically our playbook. The single biggest thing we can do preoperatively is to get them to stop smoking, and ideally for at least 6 to 8 weeks. That's long enough to reduce their sputum and let their cilia start working again. Of course, we also need to get them on the best possible inhaler therapy and clear up any infection. Intraoperatively, if you can do the case under regional anesthesia, that's a massive win. It avoids all the problems of a general anesthetic and airway instrumentation.
Then, postoperatively, it's all about preventing the lungs from collapsing and getting infected. That means aggressive chest physio, incentive spirometry, and really good pain relief. Something like an epidural is fantastic because it allows them to take deep breaths and cough effectively. Ventilating a patient with severe COPD is a very precise art, and these are the absolute golden rules. Your number one non-negotiable goal is to prevent air trapping, which we call auto-PEEP. The way you do that is by giving the patient a very long time to breathe out. That means using a slow respiratory rate, often down to just 6 or 8 breaths a minute, with a low I to E ratio. Using a slow inspiratory flow also helps the gas get to all parts of the lung more evenly. But the best way to know if you're getting it right is to stare at the ventilator screen. Look at the flow time graph. You absolutely must see the expiratory flow come all the way back to the 0 line before the next breath starts. If it doesn't, you are actively trapping air, which can cause their blood pressure to plummet and even lead to a pneumothorax.
Right, for our last section, we're going to do a bit of a rapid tour through a few less common but no less important conditions. We'll touch on things like bronchiectasis, the constant threat of a pulmonary embolism, and then finish with the biggest respiratory operation of all, lung transplantation.
Okay, let's rattle through a few key take-homes for these tricky conditions. For bronchiectasis, the big problem is the sheer volume of sputum. The key is aggressive preoperative chest physio, and if you're doing thoracic surgery, you'll often need a double lumen tube to stop pus from spilling over into the good lung. For cystic fibrosis, it's all about their incredibly thick secretions. So you need to keep them perfectly hydrated, make sure you're using a humidifier on the circuit, and avoid drugs that dry out secretions, like anticholinergics. With primary ciliary dyskinesia, the thing to remember is its link to Carter-Jenner syndrome. About half of these patients will have situs inversus, so always check the chest x-ray. You might need to put your ECG dots and central line on the wrong side. And finally, for tracheal stenosis, the challenge is just getting air past the narrowing. That might mean using a smaller tube, mixing helium with your oxygen to make the gas flow better, or even using advanced modes like jet ventilation.
A pulmonary embolism can look like almost anything. And this table shows you the common signs in an awake patient, but under anesthesia, the presentation is very different. The absolute classic sign of a massive PE in an intubated patient is a sudden, catastrophic drop in the end-tidal CO2, along with profound hypotension and hypoxia. The reason the end-tidal drops is that you've created a huge amount of dead space, your ventilating lung that has no blood flow. It's a diagnosis that has to be at the front of your mind for any sudden, unexplained collapse in theater.
Lung transplantation really is the last resort for a whole host of awful end-stage lung diseases. As you can see from the list, the reasons for it cover the entire field of respiratory medicine, from the obstructive diseases we've been talking about, like COPD and CF, to restrictive diseases like pulmonary fibrosis, and even vascular problems like primary pulmonary hypertension.
Anesthesia, a lung transplant, is probably one of the most challenging things we do, and it is the definition of a team effort. Pre-op, assessing the right ventricular function is absolutely vital, because the RV is going to take a massive hit. Intraoperatively, it's a real showcase of advanced anesthesia. You must have a double lumen tube for lung isolation. One lung ventilation is incredibly tricky. We rely on transosophial echo to keep a close eye on the heart, especially the RV, when the surgeons clamp the pulmonary artery. And you always have to be ready to go on to cardiopulmonary bypass at a moment's notice. Then post-op, the challenges just keep coming, with the careful balancing act of immunosuppression, watching for infection and rejection, and protecting that fragile new airway connection.
So, let's just boil everything we've talked about down to the absolute key messages. First, do the work up front. Optimize every patient. Treat their infection. Get their bronchospasms sorted before they come to theater for an elective case. Second, be kind to the airway. In anyone with a URI or asthma, the less you do to it, the better. Third, for COPD, your one and only goal during ventilation is to prevent air trapping. Let them breathe out. Fourth, remember that not all that wheezes is asthma. Always run through that differential diagnosis. And finally, our job doesn't end when the drapes come down. Good post-operative care with chest physio and pain relief is what makes all the difference.
And that brings us to the end. I just want to leave you with one final question to think about. We know we're seeing more and more patients with significant respiratory disease coming for surgery. So what is one small thing you can change, one question you can add to your preoperative assessment tomorrow that will help you better identify and reduce the risk for these patients? Thank you so much for listening.